We are very happy to have you join part one of a four-part series to help us discuss further how we can work together as communities to help prevent suicide, with a special emphasis on vulnerable or marginalized community members. We have Dr. Kent Corso, who is a nationally and internationally recognized trainer and clinician in the areas of suicide prevention and management. So we're very happy to have him working with us today and over the next few weeks on this training series. So Dr. Corso, pardon, thank you so much for joining us today, and I'll go ahead and turn it over to you.
Great, thanks so much, Rachel. Appreciate you having me here. Really excited to be able to talk to everyone today about PROSPER, which is proactive reduction of suicide in populations by evidence-based research. So we have about an hour today, and I've got some videos to show and some very frank, honest, straightforward discussions to have. So hold on for the ride, be prepared. It's about 2 o'clock Eastern time. I'm in the state of Virginia on the East Coast, which means you all are warming up for lunch in a little bit. So this is probably a better conversation to have now than during lunch. This is most helpful if you're actively learning. So what that means is that you're asking questions, you're using the discussion box. Rachel will help me monitor that so that we can provide the most seamless experience for you. Again, no question's a stupid question. This is kind of a diverse audience here today attending this. So I've tried to include a range of material and information so that it can be helpful to as many of you as possible. And again, this is part one in a multi-part series. So some of the things that we get started talking about today, we may expound upon and dig a little bit deeper in depth in the future. So without further delay, here are the scientific studies and research that a lot of this material is based on. Unless you're a super dork like me, don't worry about it. Here's our brief overview. We're going to talk about gatekeepers and what those are, suicide trends, the importance of language when we're discussing things like suicide, understanding suicide itself, and especially among LGBTQ persons. What that means is lesbian, gay, bisexual, transgender, or questioning. It's a heck of a mouthful, even as an acronym, so we say LGBTQ. And then how to manage suicidal thoughts or feelings, and then other resources that you might be able to use for yourself or for a loved one. So what are gatekeeper prevention programs? Well, the idea of a gatekeeper is it's someone who holds access to something that might be desirable or useful to someone else. So a gatekeeper program leverages the community. It looks out to everyone out there, just community members, first responders, police, fire, EMS, but then broader, teachers, guidance counselors, people who own local businesses, all different types of people who work in healthcare settings. So anyone who might observe a person in crisis. So often this is the most common type of program. It's the most basic or fundamental type of suicide prevention program. These type of programs exist all across the country, in fact, all across the world. And the basic idea of the programs is to give everyone some standard and basic level of information about suicide and try to help them figure out what to do if they come upon a person in distress. So it's that idea that if you see something, say something. These are the types of posters and promotional materials we saw right after 9/11. The idea that if you see something suspicious, call the police, call your local, call the FBI if you suspect terrorism, right? So really mobilizing a community to look out for itself. It's not too different from that old concept from when many of us were young called the neighborhood watch program, right? It's the idea that in a community we can help keep each other safe and keep our community enjoyable and accessible if we're all staying aware of what could potentially be unfolding around us. Well, It's one thing to say, if you see something, say something. It's another thing to actually know what to say and know when to say something. So most people find this slightly difficult. When someone is in the middle of a storm and seems to be absolutely hopeless, how do we just randomly reach out to a stranger to assist them? Well, there's this myth that says if I ask someone about suicide, maybe he or she wasn't thinking of suicide, but now the person is thinking of suicide, as if me asking actually put some sort of an idea in the person's mind. Well, the good news is there is no research to suspect or to prove that that is true. We're not going to give anyone an idea that they didn't already have. So that's the good news. Everyone should feel very comfortable that just asking a friend, a family member about it, or even someone who's a stranger, is not going to make them become suicidal. So let's get that out of the way at the very beginning of this talk. It's interesting, I'll tell a story. When I was in graduate school about 20 years ago, I worked with a young man who was on a career path to be a high-powered attorney and just had some sort of a breakdown and had several medical problems. And I remember one day when I was working with him, he told me that earlier in the day he had gone to work and he was sitting at the bus stop, because that's how he got to work, and he just broke down crying. And as I imagined him sitting there crying, feeling pretty helpless, my heart went out to him. I just thought, wow, that's got to be terrible. I don't think I've ever just sort of broken down in public. Most of us try to keep our composure in public, keep our image or pride. And so I was just thinking about that as he told me the story. And then what sounded pretty amazing to me was just a random woman walked up to him, put her hand on his shoulder and said, "Are you okay? Are you doing okay? Is there anything I can do to help you?" And this woman was not someone who is of a church or mosque or temple or anything like that. And she wasn't a physician or a nurse. She was just someone who was walking by, saw someone struggling, and reached out to help. It actually, as he told me the story, it actually helped him immensely, not because he had a long conversation with her, but because it prompted him to sort of get it together a little bit. He kind of smiled and said, "Wow, I really appreciate that." It warmed his heart. And he stood up, stopped crying, and a few minutes later the bus came. He got on the bus, and I saw him about an hour after that incident. So it's amazing how when we just reach out to people and just show some gesture of caring, how it can truly make a difference. If we can get beyond the awkwardness, the discomfort of sort of broaching that topic with someone, it actually can have a profound effect. And we don't have to be experts. We just have to be what I would call a caring human being. Okay, so when we think about what are those thoughts that people might be having and how do we ask about those thoughts, here's a list of potential thoughts. So thoughts of death or dying, wishing to be dead, wishing I could fall asleep and not wake up, or thinking of killing myself, imagining I will play a part in causing my death, planning my death, thinking about how I might kill myself. So these are the types of thoughts that we might notice, or we might even ask someone about. So this is sort of the audience participation part of the of this morning's discussion. So some of these are suicidal thoughts, and some of them are not suicidal thoughts. I've broken them up into two categories just to make it easier to read. Go ahead and type in the chat box how many of these thoughts you count. There's a list right here of 7 thoughts. How many of these are actually suicidal thoughts? Go ahead and take a moment, read them, and then put your number in the chat box. And I'll just sort of monitor it for the next minute or two as we see what people think. If you don't have access to the chat box easily, maybe you're on a phone, go ahead and unmute and just yell out your number, and I'm going to keep track of it. Okay, it looks like I've got about 25 people who voted, and we have about 31 participants, so we have the majority of you. Oh, there's a latecomer. Thank you for that. So there were 6 people who said that they counted 4 suicidal thoughts. 5 people counted 5 suicidal thoughts. 4 people counted them all as suicidal thoughts, and there was 1 person who counted 3 thoughts. So great job with that. The answer is this. So everything above is not a suicidal thought. Everything below is a suicidal thought. The reason why this matters is because in the research and in the doctors and nurses sort of language, we call this DI, or death ideation, or death thoughts. These are actually much more common than you would imagine. This is the type of thing that many of us might think a few times a year. If life is particularly tough, or a few times a month if we have some sort of a really severe, sudden stressor in our lives. It's that feeling of being overwhelmed and just wishing you didn't have to deal with it. By contrast, the thoughts below are suicidal thoughts, which means not only do I think about being dead so that I don't have to deal with it, but the key is that I see myself playing a role in causing my death. And so anything where I envision or anticipate that I might be a part of making my death happen, that becomes suicidal thoughts. So death thoughts are actually very common. Suicidal thoughts are less common. Death thoughts do not reliably, do not repeatedly, do not consistently lead to suicidal behaviors, whereas suicidal thoughts do with more consistency or reliability. So if I hear that someone's feeling this, or even I recognize in myself that I'm thinking this, that's important, but I should be even more concerned if I find myself thinking this. So part of the community approach to suicide prevention that can be so helpful is not only teaching us to help each other, but teaching us to help ourselves. Okay, and we'll get into that in a moment. But this is such a critical part here, that we understand the difference between death ideation or death thoughts and suicidal thoughts. There's a great question in the chat box, and it says, what if the thought is, I'm not going to prevent my death? So that's a common question. The idea of, well, I'm driving down the road, and what if I just take my hands off the wheel and let fate take its course? Or I'm taking this medicine for my heart, but I kind of wish I were dead. So what if I just stop taking the medicine and I let fate decide, or I let God decide? So whether it's spiritually based or non-spiritually based, if the person considers doing that action, whatever the action is, as the Kimberly Hunter in the chat box said, not preventing their death, if they imagine that that behavior might result in their death, then it's considered a suicidal thought. If they, in their minds, only believe or anticipate that the action will just lead to harm, but not death, then it's something totally different that's not even on this slide. So great question. So even, it's sort of like lies of omission versus lies of commission, which is a sort of a phrase. If I lie and I say, I did not steal that piece of candy from my daddy, that's a lie of commission. If I steal a piece of candy and no one asks, that's a lie of omission, right? I'm not giving any information either way about what I did or didn't do. And so if people sort of fail to prevent their death, or decide that they're going to do something that may kill themselves, if they think about that action potentially ending their lives, then it's considered suicidal thoughts. So what are the warning signs of acute suicidal risk? Well, if people threaten to talk about or say they want to, or you find that they're looking for ways to hurt or kill themselves, so those are signs of risk. There are some people who just do things to harm themselves, and they don't intend to kill themselves, but we still are very concerned about that behavior, because if someone engages in that behavior, it's called self-harm behavior, something like cutting behavior. Sometimes we hear about adolescents or even adults cutting themselves or burning themselves or branding themselves when they're feeling upset. that kind of self-harm behavior, when someone gets hospitalized from it, 1 in 5 people end up dying within a year. So what that means is they don't stop repeating those acts, and either it becomes suicidal behavior, or it means that they cut too deeply by accident, or sometimes that kind of self-harm behavior involves drinking alcohol excessively or doing drugs. So while that isn't the most immediate sign that someone might kill herself or kill themselves, it is something that is relevant. And so we certainly want to be concerned about that. If people talk about looking for firearms or wanting to get firearms, or trying to access medications or other means of killing themselves or ways of killing themselves, that's a sign. Talking or writing about death, dying, or suicide when these are out of the ordinary, so a suicide note. But what is ordinary? I mean, go ahead and either unmute your mic or throw a comment in the chat box. When would it be ordinary to talk about death or dying? When would that be normal? When would we not be concerned that someone's talk about death or dying has anything to do with suicide? Great comment in the chat box. When someone knows, someone they know has died, when their family members are dying, when they become close to death, right? So death and dying are not the same as suicide, of course. It's actually quite normal to think about one's own death, especially as someone in the chat box just commented, especially when someone's facing a terminal illness or some sort of a serious medical diagnosis. Another great comment in the chat box: when someone has a terminal diagnosis, when they're within hospice or any other sort of end of life care, it's completely normal to think about death. Some people think about death in more of a spiritual way or a religious way, like when they're drawing up their funeral. Great comment. We're thinking on the same page here. When they're drawing up their funeral, a will, things like that. So that's great. The key here is written down in the green space. We have to know what someone's baseline is. So if we're thinking about family, friends, the person at the grocery store, we kind of have a sense for the people who we interact with in our community regularly. Even if you live in a fairly rural area, you're what I'd call a regular somewhere. When I grew up, I worked in restaurants, waited tables, and was a bartender. And we had regulars, people who always came to the bar. Did I have a positive relationship with them? Absolutely. Did I know the foggiest detail of their lives? Absolutely not. At least not for the most part. And so we can still have a sense, we can have a positive relationship with someone, very positive rapport with someone, and not know much about them. And it's mainly because they are the faces we see each week or multiple times in a year. And so keep that in mind and tuck that away. That's going to come up later in our discussion. Here's the expanded list of warning signs. So these are sort of not as directly related to suicide, but they sometimes are related to suicide. So increased substance use, alcohol or drugs, talking about no reason for living or seeming to have no sense of purpose in life. When people are not sleeping well, agitated or anxious, sometimes if they have chronic pain, feeling trapped or stuck, hopelessness. When we see people pull back from friends, family, life, job, school, when they seem to have uncontrolled anger or are sort of fixated on getting someone back for something, acting reckless or engaging in risky behaviors that seem to happen without thinking, and dramatic mood shifts or mood changes. So as far as gatekeeper training goes, it's so important that we understand what we might see among people in our community, so that if we do see these things, we can understand that they might be related to suicide, and then maybe we'll say something. But let's be honest, what really can be done about suicide, right? There are many different ways for people to kill themselves, and there are many people who would say, if someone wants to kill himself, he has the right. If someone wants to kill herself and end her life, she has the right. And there are some states and actually many countries outside the US that do agree with that. There are many countries that disagree with the way we handle suicide in America, which is sort of like do everything you can to stop people. They have a different value system, just different belief system. Let's take a look at a video quickly. I have a few of these just to try to give this some context and make it a little bit more palpable. So these are all, these are some news clips and other clips. They're all about 3 or 4 minutes long. So without further ado, I'm gonna show you this. Let me share my screen again.
This first day of September marks the first day of Suicide Prevention Awareness Month. And for a state that has regularly ranked in the nation's top 10 per capita for suicide, the timing has never been more critical to step up that work. It's something the PsyD Foundation is already doing, following the premiere of a brand new HBO documentary that tells the story of Olympians like Boise's Jarrett "Speedy" Peterson, whose depression led him to taking his life a year and a half after winning silver in Vancouver.
The pain becomes insurmountable. And the pain that he was having, I know because I saw it.
And Speedy's mother, Linda, wasn't the only one who saw it. In the new HBO documentary, The Weight of Gold, one of Speedy's closest friends on the U.S. Olympic ski team, Jeremy Bloom, said he would never forget the night Jarrett confided in him about his daily feelings of suicide.
I just said, Speedy, look at you. You're so incredibly successful. You're a good-looking kid. You have the wind behind your sails. Like, you know, what's going on? And, you know, he just really opened up to me. And I often think about that moment. I wish I could go back to it now, because I think I would have handled it a lot differently than I did.
We as a family, I know the ski team and his support system, his friends, didn't have the tools. We don't have a general mental health literacy in the United States.
Shannon Decker is the executive director for the PsyD Foundation in Boise, which started up just weeks after her cousin Jarrett's death 9 years ago to restart Idaho's suicide prevention hotline. Shannon was part of a panel discussion involving, among others, the film's director and also executive producer Michael Phelps, who holds the all-time record for Olympic gold medals at 23. Despite being the most decorated Olympian of all time, Michael Phelps says he's been dealing with mental health issues for most of his adult life, saying our society's push for physical health and performance has never contained a mental health and awareness component.
I think the one thing that frustrates me the most is that we've seen so many instances where athletes have gone through these scary times, and we know about them, but there's still nothing that's been done about it. That's the screwed up part.
And though the film focuses on Olympians, they all know that's just a small section of those affected by this.
It's people everywhere. I think we're finally starting to talk about mental health and mental wellness. Really, mental health is being elevated to the same level as physical health. I saw the coaches lineup for the Bishop Kelly football coaches this year as far as their professional development. And for the first time ever, there was a suicide prevention module that was included. And if you can talk about suicide, you can talk about anything else. It is probably the hardest thing to talk about with someone individually. But if you're starting to notice the signs of what might be concerning about suicide, you're in tune to anything and everything else.
The PsyD Foundation has a free online class for anyone looking for clues to knowing when someone is in crisis, and then being given a roadmap for navigating the best way out, something that those who are close to Speedy didn't have access to at the time, something that just may have changed history.
1 hour of your time could save a life, and you might not know when, and you might not know where. You might not ever know that it happened, but you start to change your mindset. You start to change the way that you speak to other people, the way that you reach out when you see that someone is maybe struggling, and connect them to help.
That mental health first aid training is available on the PsyD Foundation website. You'll find a link to it in this story on our website.
Okay, any quick thoughts or reflections about that before we get back to our discussion? Want to just put something in the chat box here. One of the things that Speedy's, the teammate of his on the ski team, he said when Speedy confided in him, the three things he told us that he said were, you have everything. You have the wind behind your sails. What's going on? It just goes to show that it is very different when you are the person feeling suicidal and when you are someone else who learns about it. So we have to be very careful presenting another image of the person than the person feels. It can be actually pretty rejecting, invalidating. There's this thing that we do as humans where we try to talk people off the ledge. We try to get them to think about all the things they have going for them. And that can actually backfire. It can actually have the opposite effect. Now, there is a certain way we can talk about to people, and we'll discuss that at the very end of today and probably go into it next time at our next segment. But we have to be careful saying things like, well, you have everything. Why would you want to kill yourself? What you have, that it can be really rejecting. But there are some other things we can do as that family member of his who is in charge of the Speedy Foundation said, we don't have a lot of mental health literacy in our country. And this is true. It means that we don't truly understand what mental health is, what mental health terminology is out there. And when we specifically apply it to suicide, we have to understand what is suicide and what isn't suicide. So a few moments ago, we went over what are suicidal thoughts versus death thoughts. That's actually a mistake that many people make. They confuse the two. Thoughts of death are really just that. They're all about escape and feeling overwhelmed, whereas thoughts of suicide are about causing one's death, and that's obviously much more concerning. So what we're going to do for the rest of today is try to increase our mental health literacy and identify what we see in others and what we can see in ourselves that may suggest there's some suicidal thoughts there. And then ultimately, over time, we have to know what to do about it. Now, a major focus of this discussion is also the LGBTQ population. When we think of underserved or marginalized populations, what we mean is these are people whom are struggling, but either have more difficulties accessing services, they're actively shut out of services, or there may be more stigma to accessing services. A good example is I've done a lot of work with the military. I'm a prior U.S. Air Force officer. That's where I was trained. And military people and veterans generally avoid seeking mental health treatment. And the reason is because it can hurt their career. Likewise, firemen, policemen, EMS, they avoid seeking treatment, mental health treatment, because it can affect their career. No police officer wants to have her gun taken away, her firearm taken away, because she's talking about having marital problems or anxiety or depression. Likewise, within the Black community, the African-American community, it is far less acceptable to be gay compared to the white community. So there's a good example of where someone would be even more marginalized. 10 years ago, the transgender community were seen as sort of the redheaded stepchild of the what then was just called the GLB community, the gay, lesbian, bisexual community. And so they have been marginalized for years. So it's important that we look at how suicide works for humans in general, but then also these specific populations, because they have unique barriers that sort of limit them from accessing care or being treated well or effectively by the system. But one thing I want to, well, actually, you know what? I'll save that point till later. So gatekeeper programs are great, but here's another audience participation question. Why might gatekeeper programs sometimes fall short of solving the problem? So you can unmute your mic or throw a comment in the chat box. Where might gatekeeper programs fall short, or why might they fall short, or when might they fall short? Where are their limitations? So the chat box is blowing up a little bit. So people saying lack of screening. Yeah, it may just be getting someone to help, but there's no screening, and we'd want screening for everyone early on so that we could proactively identify who needs help, not just reactively get them to help. Stephanie, a great point. There's bias. We all have our own assumptions, biases, beliefs, you know, and because we're all different. Another comment is that there's a lack of resources. Another comment is that people don't want to intrude on others. They don't want to impose. It's sort of like, well, I really feel like I should mind my own business. And then someone else pointed out that there was a lack of coordination or connections within the system. All of those are great answers. Final answer there may be language and cultural barriers. Absolutely correct. So here are our reasons. The right help isn't always available, and not everyone is always willing to help others. They might want to mind their own business. And then by the same token, not everyone who needs help actually wants to accept it. Men, for example, the research shows that, and I am a man, so I can say this sort of very openly, men are terrible help seekers, terrible help seekers. This is why women, probably partly why women live longer than men, because men are just not great at self-care. We know from research that when if a man and woman are married and the man dies first, women actually adjust quite well to the death of their spouse. But when a man and woman get old and they're married and the woman dies first, men actually go downhill quite rapidly when we look at their health and their mental health. And so not everybody wants help. And then there's culture, right? Is there anyone on the line who might identify with a local culture in your state or in your region of the country, a cultural value, like something like appreciating self-reliance, self-sufficiency, being able to use a tool to manage something yourself versus asking for help or reaching out for help or accepting help. And then some people may feel like they're being targeted or criticized. It's not always easy to accept a stranger walking up to you. So you all hit the nail on the head there. Here's the problem that we also run into is we have suicide profiling. So what is the profile of the person who's most likely to die by suicide or attempt suicide? It's a white male between the ages of 18 and 35 who owns a firearm. Well, okay, so we know what the profile is, but so what? How is that going to help us as a community to decrease suicides? I mean, don't females kill themselves? Don't people of color kill themselves? Don't people who are not 18 to 35 kill themselves? Don't people who are gay or transgender kill themselves? Of course they do. In fact, we see very high rates of substance abuse in the GBLTQ community. We see high rates of suicide in that community. Don't people kill themselves in ways that don't involve firearms, like hanging or poisoning or overdosing on drugs? So in other words, has knowing all of these facts that white males between ages of 18 and 35 who own a firearm, they're the ones who are most likely to kill themselves, has knowing those that profile helped us decrease suicides over the last 50 years? It actually hasn't. So we've known the statistics for decades. Likewise, there are triggers to suicide. We know that there are these are the 7 most common triggers that lead people to think about killing themselves and attempt suicide. So relationship problems, those take the cake. 42% of people who die by suicide or attempt suicide, died by suicide, had a relationship problem. 28% had a substance abuse problem, 16% job or financial problem, 4% loss of housing, 9% criminal, legal, 22% a physical health problem, and about 30% had a crisis in the past 2 weeks or has one upcoming in the next 2 weeks. So this is important to know, because if we have friends or family who encounter these, we should be a little more vigilant and maybe extend a caring word or a caring gesture. At the same time, there are plenty of people who lose their job or have a legal problem or a physical problem who don't kill themselves. So we've known these facts for decades as well, and we can't use them as predictors to look at the 1,000 people who live in our community and try to pick out who's likely to kill themselves. In fact, recent research has shown that we do not have the ability to predict future suicides by looking at things like race or age or a recent crisis. So what do we do instead? Well, before we go there, this is just a visual to explain why we're not bending the curve. We're not changing the suicide curve. It just keeps increasing. The black line are the total suicides from 1981 to 2016. The dark red line are males, the light red line are females. If we look on the right side here, the top two of the top causes of death in our country are diabetes and heart disease, accidents, and these are decreasing. All causes of death, we are getting better at managing them. But for suicide, we're not. It just keeps climbing. If we take a closer look at the state of Idaho, Idaho is typically in the top 5 of the worst states for suicide over the last 10 to 15 years. And if we just look from 2011 all the way through 2019, the circles here are the rates in the United States, and the squares is the rate in Idaho. Now, just a note here, suicide is among the top 10 causes of death for adults in America, and it's the number 2 cause of death for children ages 10 to 17, excuse me. And the way we try to look at these numbers to break them down into more workable bites or portions is to look at the number of suicides per 100,000 people. And so as you can see, the US on average, the rate is a little over 14 people per 100,000. But in Idaho, it's almost twice that. It's 24 per 100,000. So while there are many efforts, and we just saw the PsyD Foundation is doing a lot this month, and there are other people, other organizations doing a lot. September is Suicide Prevention Month in America. Clearly, we're not there yet, okay? And it's partly because we may know very well that there are risk factors, that there are triggers for suicidal thoughts. What people are less aware of is what this is. This is something called the suicidal mode. This is what people experience. Think of it as a gear or a state of mind or a state of being that they get into when they become suicidal. So we all have predispositions, whether they're genetics or biological, things that make us vulnerable to becoming suicidal. And then there's a trigger, right? On the 2 or 3 slides ago, we looked at what those triggers are. And when that trigger happens, some people who have predispositions, when the trigger happens, the suicidal mode will turn on. The suicidal mode is this combination of thoughts, feelings, and behaviors, and physiology. So they might feel ashamed, angry, depressed. They might think about blaming themselves or think like, I'm a terrible person, I'm a burden to others, this is hopeless. And then they might engage in behaviors that go along with those thoughts and feelings, where they withdraw from people, or they start to think about killing themselves and they start to rehearse it or plan it. And all the while, they have physiology going on, and that's important. What happens in their body is typically they're very agitated, they're very irritated, they may not be sleeping well, they have trouble concentrating, they might have sort of racing thoughts, so they're kind of worked up. The key here is, number one, we have to, as just humans, forget physicians, forget EMS, forget first responders, every human has to be able to recognize when this is happening to themselves. If we can't recognize it in ourselves, it's much harder to recognize it in others, okay? And so that's what we're gonna spend some time talking about today, and we'll talk about it next time as well, is how can we recognize this when it's happening to us? And then of course, how can we recognize when it's happening to others? Because that's a reliable that is a sign, that is the exact sign of suicide. So if we can look for that versus trying to look for people who own firearms or look for people who are GLBTQ, sure, we'll find some who might become suicidal, but who knows when. And then we're definitely going to find others who are never going to become suicidal. There are many people who own firearms or who are white men between the ages of 18 to 35 who never think about suicide. So we've got to get out of the mindset of profiling and actually look for the exact sort of symptoms and signs of the problem. Okay, so going to dig into another video clip quickly.
And Dr. Corso, as you're pulling that up, there's a question in the chat box regarding substance abuse. Is that something you have a moment to detail a little bit more?
Absolutely. So substance abuse is usually, it is a behavior. If I abuse substances, that is a behavior I do, a decision I make. And so we typically would not look at that as a trigger. What we do look at it as is sort of an accelerator. So think of when someone is drinking, it's possible that they might think of killing themselves. And it's not that the alcohol made them kill themselves, it's that it took down their inhibitions. So alcohol kind of removes our filters. We become less controlled, less composed. Any inkling, any fleeting thought, any impulse is much more likely to come out. So alcohol, we think of alcohol as an accelerator of risk, but not a trigger itself. Now, I guess there's a small percentage of people in our country who have a chronic alcohol problem, and that causes all sorts of triggers like loss of job, unstable relationships, isolation. And so in that sense, it could be a contributing factor for suicide, but more because of how it's affected the person's life over time, not just the episode of drinking itself. Great question. Okay, let's take a look at this.
And a funeral is being held this morning in Florida for Rebecca Sedgwick. The 6th grader committed suicide last week. Authorities say she suffered nearly a year of cyberbullying. As Michelle Miller reports, more than a dozen of her classmates could be held responsible.
Last Monday, 12-year-old Rebecca Sedgwick climbed to the top of this abandoned cement plant and jumped to her death, finally giving in to the girls that had tormented her online for months.
They wanted her to kill herself. You haven't killed yourself yet? Would you please just die? They got what they wanted.
Her mother, Tricia Norman, says the harassment started over a boy. She tried to get Rebecca away from the bullies by complaining to school officials. She then pulled her out of school, changed her cell phone number, and shut down her Facebook account. But the attackers moved to a variety of messaging apps.
The bullying continued by a group of female juveniles on different social media outlets.
Authorities are now exploring if charges can be brought against the 15 girls. Earlier this year, Florida expanded its school bullying law to include cyberbullying and some off-campus activities.
Becca wrote this down in her journal, and it says, every day, more and more kids kill themselves because of bullying. How many lives have to be lost until people realize words do matter?
Hi, this is my random video.
In the weeks before Rebecca's death, her mother thought the abuse had stopped. She says she had no idea that Rebecca had changed her username on one messaging app to That Dead Girl. She also didn't know about the troubling online searches for razor blades.
Another question she asked was, how many Advil do you need to take to die?
A memorial has sprung up on the fence surrounding the concrete plant where Rebecca took her own life. And Rebecca's family has started a Facebook page to help stamp out cyberbullying.
That was my heart. I loved her so much. And this is the least I can do for her. Nobody else would listen. Now that people are finally listening, now that she's gone, I'm not going to let it go.
For CBS This Morning, Michelle Miller, Lakeland, Florida.
You know, as a
Okay, pretty deep stuff. I told you we were gonna talk about some serious stuff today. So any reflections, observations, or comments about that, go ahead and leave them in the chat box. There were a few things that are pretty important that were mentioned in that video. One of the things was cyberbullying and sort of harassment and how words can really harm people. Something else that was mentioned was how she changed her name to That Dead Girl on one of the sort of messaging apps. We have to remember that children, and she was 12, but even teenagers, they believe what we tell them they are. If we say you're a bad kid, they start to believe they're a bad kid. And then not surprisingly, they act in a bad way. They behave in bad ways. And so whether the words come from adults or kids or teachers or others, they matter. And so also the idea that she was asking about Advil and how many you need to kill yourself, or looking for razor blades online. These are all of those warning signs that we listed a few moments ago. But it also has a lot of relevance for the LGBTQ community, because what we see among adults in this community is that when they are treated with what's called microaggressions, so this is basically like harassing behaviors, name calling, mean behaviors, when people stigmatize them, when they make fun of them, we see that it's a risk factor for depression and attempted suicide. And among those who are transgender or struggling with their gender identity, it's a risk factor for depression. We also know that as I said before, suicide is actually pretty high in the LGBTQ community. And in fact, the suicide rate among those who get the gender reassignment surgery, the suicide rate after the operation is higher than all post-operation suicide rates combined. So that's pretty concerning. We have kids earlier and earlier talking about gender. We have, these conversations happen earlier now. Certainly with the internet, people see a lot of things that years ago folks didn't see. Even some adults didn't see. Let's talk about kids and adolescents. So suicide and self-inflicting injurious behaviors. So that's like, again, cutting or other non-lethal self-injurious behaviors in the LGBTQ community are associated with mental health challenges like not being accepted by peers, being discriminated against, being rejected by their family, or having difficulties in school. And we know that the risk factors among LGBTQ youths include bullying, feelings of hopelessness, cultural and religious beliefs that are contrary to their sexual orientation or gender identity, and then they're unlikely or unwilling to seek help because of the stigma that's attached to it. So it's interesting because there are the only thing in all of these risk factors that make LGBTQ kids and adolescents at risk for suicide, there's only one that is unique, and that's the cultural and religious beliefs. There are many groups that feel stigma and therefore don't seek help. There are many people who feel hopeless. Now, in this case, it has to do with them adapting to their sexuality or living with their sexuality openly. So these factors are common to many different types of people. So I want to be clear here. There's not decades and decades of research on suicide within the LGBTQ community. If there was, gosh, I hope we'd be doing better with everyone in general, including this group of folks. But the reality is we still don't get suicide as a whole. We still are learning how to crack that nut. And so while we have to be very mindful of these specific risk factors for the LGBTQ community, we can't look at them in isolation, and we have to keep our eye on the other things that are common. Just want to go over terminology for LGBTQ. An ally is someone who's not LGBTQ, but who shows support for those people or promotes equality or advocacy in a variety of ways. Cisgender, this is a person whose gender identity aligns with the sex assigned to him at birth. So I am cisgender if I am a male who has male genitalia, XY chromosomes, and I feel like a male. Gender identity is one's innermost concept of what it means to be male, female, it could be a blend of both genders or neither. When you look at non-binary right below, that's a good example of people who don't really identify as being male or female. They may say, I'm kind of both, or I'm somewhere in between. And finally, transgender is an umbrella term for people whose gender identity and or expression is different from the cultural expectations of the sex they were assigned at birth. We know common terms like tomboy, right? We might see a male and call him more feminine, or see a female or male and call them androgynous, right? There's an old Saturday Night Live skit. What's that? It's Pat, and it's this male or female, no one really knows, and they kind of make fun of it in the fact that everybody at the person's job, Pat's job, continues to try to figure out, is Pat a male or female? And so they ask her questions like, oh, what'd you do this weekend? And where do you go shopping for clothes, to try to understand it? And there's this social thing we do where we treat men one way and we treat women another way. And so if people are either a mix of both, a kind of feminine and masculine, or it's unclear what they are, we tend to struggle with, how am I supposed to treat that person? And I'm not saying that's fair, but that is just the way human social behavior works. And so that's why gender identity is important. That's why LGBTQ is so important, because it relates to how we behave socially in reference to each other. So there's a great, this is a great resource under here. This is the Human Rights Council. Great link. It has probably a list of 50 terms or maybe 30 terms. So I encourage you to check it out. But let's also look at suicide language more broadly. We hear people say things like, oh, it was a cry for help, or oh, this person committed suicide. And when we talk to people who have survived suicide attempts, when we talk to people who have loved ones who died by suicide, they don't like these terms. All of these terms are judgment laden, they're value laden, and they may even be derogatory. But at the end of the day, they don't really tell us much about what's going on. So I would encourage you to avoid using these words. In fact, the most common one we hear people say is commit suicide. There are two things we generally commit, and those are crimes or sins. And so in that sense, again, it places judgment on the person and the person's behavior. So instead, say that person killed herself. She died by suicide. She ended her life. Those are the three alternatives to she committed suicide. Here are some other related terms. I think we're going to skip these for now in the interest of time. I only have about 10 minutes left. We'll go over these. I planned to go over these again at the next segment, and so we'll just save them for then. But here's something important that we should consider. If we're ever going to help ourselves or help someone else, go ahead and answer these questions. I'm going to read them out, but answer them in your mind. Don't share with us. Why do people kill themselves? Just think for a moment. Why do people kill themselves? What do I believe morally, spiritually, and or religiously about suicide? What type of person makes a suicide attempt? Can suicide be prevented? Who do I know who has been suicidal, made an attempt, or died by suicide? What do I think about my own personal thoughts of death, dying, and or suicide? How have the suicide deaths of my patients influenced my practice habits? So when we say practice, we're talking about healthcare. How do I seek healthcare? This is one that we usually use when we're talking to healthcare providers. And the same as the next one. So the reason we ask these questions is we all have our own biases and beliefs. We're all influenced by different cultural elements. And if we assume that the LGBTQ community is a separate culture, we have to consider how we might be biased to either help them or not help them. And for that matter, how we might help ourselves or not help ourselves. We know that within a regular primary care clinic, between 1 and 10% of patients experience suicidal symptoms at any given time. And we know that of the people who die by suicide, 45% visited their primary care provider within a month. 20% visited their primary care provider within 24 hours. And 73% of the elderly who die by suicide visited their primary care provider within the last month. And here's the thing. They didn't visit because they were thinking of killing themselves. In fact, the top 5 chief complaints among all of those appointments where that person died shortly thereafter, 1 was anxiety, 1 was depression, but then 3 had nothing to do with mental health. So unspecified GI or gastrointestinal symptoms, unexplained cardiac symptoms, and high blood pressure. So what this means is that when people are feeling sick and they're suicidal, they still go to the doctor, okay? And if we don't get help, suicide risk tends to get worse over time. And that we might have periods where we flare up, but it just tends to get worse. So suicide is a state of hopelessness, burdensomeness, powerlessness, and what we call thwarted belongingness, which means you so desperately want to be a part of something, but you're either not able, not capable, or you're being shut out. And so we think of the LGBTQ community, that's a good example of thwarted belongingness. And at the end of the day, suicide is a state of ambivalence. Remember, we just talked about how the top 5 chief complaints among the people who killed themselves shortly after their primary care appointment, 3 out of the 5 were not anything having to do with mental health. So stomach pains, or stomach distress, cardiac pains, and high blood pressure. So again, people are ambivalent. They feel both ways about it. When they're feeling sick and they're suicidal, they'll still go get help for themselves. So people seek help because there's a part of them that wants to live, even if it's minuscule. People become suicidal because they don't know how else to fix their suffering. They become suicidal because they feel overwhelmed and don't believe there's a way out. So it becomes just a way to solve their problem. It's a very escape-oriented thought process. But this is such an important way for us to all think about suicidal thoughts. If you've had your own suicidal thoughts, consider this. If you would reach out to someone else, consider this. When most people think about suicide, they don't think about only dying. They think about not wanting to live with all their pain and all their stuff. So it's not this moment of, oh, I'm not sure whether to go left or right. I'm not sure whether to live or die. It's actually feeling both things at the same time. And that's actually good news. When we share that with suicidal people, they actually are quite relieved. So consider asking yourself questions like this. We're going to go over these again next time, so I'm going to go through them quite quickly. These are just different ways of talking about ambivalence. And as we said before, we kind of mentioned these, so we're not going to go over them again. So how do we overcome it? Well, if we increase our sense of purpose and meaning in life, that can help us. If we effectively cope, and if we manage our thoughts and our feelings in more healthy ways. At the end of the day, remember this, the suicidal mode, if we switch this off and keep this off, that's what helps people live, okay? Just sending them to the hospital, for 72 hours, 40 hours, that doesn't help people live longer. In fact, 1 out of 4 people who are hospitalized for suicidal thoughts or behaviors, they get out and 1 out of 4 kill themselves within 7 days of being discharged. So the key is to switch off the suicidal mode. And in the next series, we'll talk about how to do that, or the next few segments. Before we go today, I want to leave a few minutes for questions, but also leave you with some resources. These are Idaho-specific resources. There's an Idaho Suicide Prevention Hotline that one of the videos we watched today mentioned. 208-398-HELP or 4357. And of course, there's a National Suicide Crisis Hotline, which is 1-800-273-TALK or 8255. The American Foundation for Suicide Prevention is a nonprofit organization. There is a local chapter for Oregon and Idaho. Here is the person's name. Here is the person's number. If you join it, it's just a great way to be a part of the solution and also to have information. Here's some other general resources. This is another nonprofit suicidal organization in America called suicidology.org. SPRC is the Suicide Prevention Resource Center. This is a part of SAMHSA, so this is our U.S. Department of Health and Human Services oversees this. And then specifically for children and adolescents, here are some resources. Finally, if you're looking for LGBTQ specific resources, there's the trevorproject.org, the National Suicide Hotline, of course. This is a separate hotline just for folks in this community. And then again, in the Suicide Prevention Resource Center, there's some resources on serving special populations like the LGBTQ community. So that's my email address at the bottom. Feel free to reach out if you have questions or comments, or if I can help at all. I give this out every time I do these trainings, and you'd be surprised, I get several emails, and I'm happy to field them. Any questions before we stop today? I think we've got about 2 minutes.
So hearing no questions at the moment, feel free to jump in if you're just noodling on it. I just want to extend another huge thank you to Dr. Corso, already giving some great feedback from our participants. So thank you again, Dr. Corso. I want to remind participants that we will get content back out by the end of this week. So if you have anyone you would like to share with, we'll get that back out to you. Also a reminder that we will have Dr. Corso presenting for the next 3 weeks as well. This is part 1 of a 4-part series. So please make sure you register. If you need any assistance in that, please reach out to me and I'd be happy to help. So thank you everyone so much. Just following up the slideshow, we will send out a PDF of the content. So you will have that as a reference as follow-up. Any other questions, any other comments before we head off into the day? All right. Well, thank you all for attending. Thank you for your time. Thank you for the work that you do in your communities. And Dr. Corso, thank you so much for your assistance today, and looking forward to hearing from you more over the next couple of weeks.
You're welcome, Rachel. Thanks so much for the support. Great working with you all, and I look forward to speaking with you next time.
All right. Thanks so much, everyone. Bye-bye.